Hello everyone, my name is Amir Hayat. I am the hematology registrar from Huddersfield Royal Infirmary. Welcome back in Hematology Daily Bleeps. Let's talk about the anticoagulant related bleeding reversal. As a hematology registrars, we receive a lot of calls from the emergency department that patient is taking Apixaban or Rivaroxaban or Edoxaban, and now the patient has a bleed. What to do with the bleed and how to reverse it. Or the patient is on low molecular weight heparin. Now the patient is having bleeding. What to do with this bleeding now? And the patient is on unfractionated heparin infusion. What to do with this bleeding now? So the basic principle uh, is that make sure you have stopped the anticoagulant from the drug chart and you have informed the patient not to take this medication without the advice of the doctor. Because sometimes we cross off the medication from the drug chart, but patient continues to take them um, because they will say, we have not been informed by anyone to not take this medication anymore. So it's better when you are dealing with anticoagulant related bleeding, you have informed the patient not to take the anticoagulant or blood thinner tablet. This is the first important step. Then the caller who is calling the hematology registrar or the consultant regarding the bleeding reversal, he should know what was the anticoagulant, why the patient was taking this anticoagulant, what was the dose of the anticoagulant that he was taking, what was the time when the last dose of the anticoagulant was taken, what are the what is the full blood count, liver function test, renal function test of the patient, and where is the bleed? It is isolated bleed, only intracranial bleed, or if the patient has other systemic bleeds as well, and whether local measures have been applied to stop the bleeding or not. And correcting the hemodynamic status of the patient is the medical team job or the emergency team job. This is not the thing that should be addressed by the hematology registrar on call or consultant on call. If your patient is hemodynamically unstable due to bleeding, you should activate the major hemorrhage protocol if indicated. Hematology should not tell you that you should activate major hemorrhage protocol. We have multiple cases like this where uh, personally I received a call from the ED that one of the ED, I have worked in many of the trusts, that my patient is having Apixaban and now he is admitted with upper GI bleed and the blood pressure is very low. Systolic blood pressure is 70, and they said that we have not activated the major hemorrhage protocol yet. So I mentioned to them that this is your decision. You are reviewing the patient, and if your patient is hemodynamically unstable, you should not wait for my call or hematology consultant on call advice to activate the major hemorrhage protocol. Then uh, let's talk about the anticoagulant. First one is the heparin. So heparin can be either unfractionated heparin, IV form, or the low molecular weight heparin, the subcut form. Unfractionated heparin has a very low half-life, 45 to 90 minutes, and low molecular weight heparin has a bit longer half-life, up to 4 hours. It is very less likely in routine on calls that you will receive a call from someone that my patient is receiving unfractionated heparin and there is bleeding. But if you do receive a call, then the reversal agent is protamine. And protamine has a tendency to reverse nearly all the unfractionated heparin, while it can only reverse 60 to 70% of low molecular weight heparin. So remember this difference. It can be asked from you in the FRC Part exams as well, both Part 1 and Part 2, or it can be a viva question as well. Protamine, you can give maximum of 50 milligram in one go, and it has a half-life of 7 minutes. So you need to be very quick in giving protamine, otherwise it will be wasted. And it has multiple side effects as well, like allergic reactions, sometimes anaphylactic reactions, skin rashes, and bronchospasm. Okay, so how to give protamine to a patient who is receiving um, unfractionated heparin? So, in case of unfractionated heparin, you need to give 1 milligram of protamine for every 100 units of unfractionated heparin. If someone is, for example, using um, 18 units per kg, which is the maintenance dose of the unfractionated heparin, 18 units per kg per hour. It may be different in different trust, but I'm talking to you about my trust. And if I'm using 18 units per kg per hour of unfractionated heparin, then in the last 2 hours, I would have used almost 2560 units. So if 100 units require 1 milligram of protamine, 2600 units will need 26 milligram. So the vial come in 25 milligram. So I can give this patient 25 milligram of protamine to reverse the given unfractionated heparin. Maybe the patient is on higher dose because we check the APTT ratio after 6 hours, and in unfractionated heparin protocol, if it is, for example, patient is using higher dose, maybe 25 units per kg per hour of unfractionated heparin, then you may need a higher dose according to the formula. 1 milligram protamine neutralizes 100 units of unfractionated heparin. So calculate how much unfractionated heparin has been given to the patient in the last 2 hours, and then calculate the dose of protamine for it. Practically, we do not do that much calculation. There is an app, uh, ClinCalc is an app. If you write heparin reversal, ClinCalc, ClinCalc, like MedCalc, you will see the app. When you open it, it will tell you how many units per kg this patient is using, and when was the heparin stop. They will calculate the dose automatically for you. So kindly check this app or site in the Google. It will be very easy for you as well. Same app is used for low molecular weight heparin as well, in which we want to calculate the dose of protamine for the patient. Kindly check the unfractionated heparin protocol on your trust intranet. Different hospitals have different recommendations regarding loading doses and maintenance doses. The loading dose is 75 units per kg. Maintenance dose is 18 units per kg in my trust. It may be a bit different in your hospital, but it is nearly the same in the range of 70 to 80 loading dose among all the trust. So better to look at the unfractionated heparin protocol in your hospital. Then the next one is the low molecular weight heparin. We mentioned to you that its half-life is around 4 hours, and protamine half-life is 7 minutes. We need to find out whether the last dose of low molecular weight heparin was given in the last 8 hours or more than 8 hours. Because if the last dose of low molecular weight heparin was given within 8 hours, then I can give this patient protamine 1 milligram for every 100 anti-10A units of the low molecular weight heparin. Rinzaparin 100 units is equal to 100 units of anti-10A. So to avoid these big calculations, use that app. It will be very easy for you to calculate how much dose I need for the patient. Use that app, and for example, if your patient is using 16,000 units of deltaparin or fragment, it will tell you that it will ask you first whether the dose was given less than 8 hours or more than 8 hours, and it will automatically tell you that you need 50 milligram of protamine for your patient, and it will tell you how they had calculated the dose for the patient as well. The calculation is given under the result. If the first dose of protamine is ineffective, 50 milligram you have given, this is 50 milligram is the maximum dose of protamine. If it is ineffective, then you can give another dose of the protamine, but the dosing regimen calculation will be reduced. Now you will be giving this patient 0.25 milligram per 100 units of anti-10A of the low molecular weight heparin. If the patient has taken low molecular weight heparin and there is bleeding related to it, and more than 12 hours have passed after the last dose of low molecular weight heparin, in such case, only local Mayers are usually used. Protamine is rarely indicated. So this was about low molecular weight heparin. Next one is Fondaparinux. We know that Fondaparinux has a very long half-life, 17 to 19 hours, and there are no specific antidotes for Fondaparinux. If there is severe bleeding or life-threatening bleeding related to Fondaparinux, then the only option is Novo-7 that we give to these patients to reverse the effect of Fondaparinux. Then Dabigatran. For the Dabigatran, we have a monoclonal antibody. The name is a bit difficult to take. Idarucizumab, or the trade name is Praxben, that we give to these patients to reverse the effect of Dabigatran. Its dose is 5 gram. The vial of Praxben come in 2.5 gram in 50 ml solution, and we have to give this injection over 5 to 10 minutes. Usually 5 gram is enough to reverse the effect of Dabigatran. If not, you can repeat this injection again as well to the patient. It is quicker to act than the dialysis. Now, mostly the most widely used agent to reverse Dabigatran is Praxben rather than dialysis. Then the next important thing in this discussion is DOACs reversal, Apixaban, Edoxaban, and Rivaroxaban. There is no antidote in general for these three medications, but if the patient has life-threatening bleed secondary to Apixaban and Rivaroxaban, and the bleed is in the gastrointestinal area, then we can use Andexanic alpha in this patient as well to reverse the effect of Apixaban and Rivaroxaban only. Not recommended yet for Edoxaban, but if you are in Scotland, you can use this for Edoxaban as well. But the bleeding should be gastrointestinal. So some trusts have also added that if it is life-threatening gastrointestinal bleed, or it is a severe gastrointestinal bleed that that have caused a drop in the hemoglobin more than 20 gram from the baseline. This would also be an indication of Andexanet alpha for reversing Apixaban and Edoxaban. Practically, you should not get a call from the emergency department that we have a patient on Apixaban and Rivaroxaban and there is life-threatening bleed, or there is a severe GI bleed and the patient is hemodynamically unstable. We want to reverse it and Andexanet alpha. Because in my trust, there is a protocol attached in the emergency department. Whenever a patient comes with DOACs related bleed, Apixaban and Rivaroxaban related bleed, and it is GI bleed and life-threatening or very severe bleed, they do not call us because it is a life-threatening bleed. Um, it may lead to delay in administration of Andexanet alpha to the patient. So they have a protocol attached in the emergency department and they act according to it. Okay. They only inform us that we had a patient on Apixaban or Rivaroxaban and he has a or she has a life-threatening bleed and we have given andexanet alpha to the patient. So andexanet alpha has two dosing regimen. One is low dose protocol and another one is high dose protocol. The low dose protocol is 400 milligram bolus injection in 30 minutes. In over 15 minutes. And the follow-up dose is 480 milligram in 2 hours. Then the high dose protocol is 800 milligram IV bolus in 30 minutes. And then the follow-up dose is 960 milligram in 2 hours. So two dosing protocol, low dose protocol or high dose protocol. If you are working in UK, your hospital must have andexanet alpha protocol. Go and open that and paste it in your office for the exam purpose, so that you can remember it because it can be asked in the part 2 Viva or in the part 2 coagulation paper question as well. So whenever a patient comes to ED, the emergency physician usually check what was the DOAC. Was it Apixaban or Rivaroxaban? What was the dose? Was he taking 2.5 milligram BD Apixaban or 5 milligram BD Apixaban or 10 milligram BD Apixaban? Or was it 10 milligram uh, Rivaroxaban, 15 milligram OD Rivaroxaban, or 20 milligram OD Rivaroxaban? The dosing of the DOACs are also important. So if the patient has presented within after 8 hours, for example, if the patient has presented after 8 hours, then you will always use low dose of andexanet alpha protocol, irrespective what dose of apixaban or rivaroxaban the patient has taken. Okay, if the patient has presented more than 8 hours, then you have to prescribe andexanet alpha low dose protocol. Okay, irrespective of apixaban dose and rivaroxaban dose. If your patient has presented within 8 hours of last dose of apixaban and rivaroxaban, you need to find out what was the dose of apixaban or rivaroxaban. If he was taking 15 milligram OD rivaroxaban or 20 milligram OD rivaroxaban, or if he was taking high dose of apixaban, like 10 milligram of apixaban BD, in that case, you will give this patient high dose protocol of andexanet alpha. Okay, the high dose was 800 milligram bolus of andexanet alpha over 30 minutes, followed by 960 milligram of andexanet alpha over 2 hours. If your patient was using small dose, like 10 milligram andexanet alpha, 10 milligram of rivaroxaban or 2.5 milligram BD of apixaban, in that case, and he has presented in less than 8 hours, in that case, you will give low dose regimen of andexanet alpha, which is 400 milligram bolus, IV bolus in 15 minutes, followed by 480 milligram of andexanet alpha in 2 hours. So in andexanet alpha, um, uh, you need to find out when was the last dose of DOAC, less than 8 hour or more than 8 hour, and what was the dose the patient was taking, whether it was high dose or low dose. Any patient on DOAC related life-threatening GI bleed presenting to the ED more than 8 hours, then you can give andexanet alpha low dose protocol for reversing apixaban and rivaroxaban. If your patient is taking low doses of apixaban and rivaroxaban and presented to ED with life-threatening GI bleed, and presented within 8 hours, then again you have to give this patient low dose protocol of androgen alpha. If your patient is taking high doses of Rivaroxaban and Apixaban, presented to ED within 8 hours of um, last dose of Apixaban and Rivaroxaban, then in such case, you will give this patient high dose protocol of androgen alpha. So these are the few important points. Practically, we are not dealing much with life-threatening Apixaban and Rivaroxaban related GI bleed uh, because they are dealt by the emergency physicians directly. They have the protocol attached, and Xander Alpha is present in the ED departments as well, and they source the medication from there. The one which we deal mostly are the DOAC related uh, other bleeds, intracranial bleed or bruising, excessive bruising, or bleeding from the cannula side, catheter side, etc. So this was a small talk related to DOACs related bleed and the heparin related bleed. We had already talked about warfarin related bleeding in the previous talk. The other discussion will be related to antiplatelets related bleeding. Patient on aspirin and has a bleed, what to do? Patient on clopidogrel and has a bleed, what to do? It will be in another talk. If you have any question, you can write your question in the comment section in the YouTube, or you can ask question in the WhatsApp group, which we have made for the hematology community. Thank you.